Hi, everyone, and welcome to Let's Talk Risk, where our mission is to engage, inspire, and empower the global community of risk practitioners. I'm your host, Naveen Agarwal, and today I'm super excited to welcome Richard Mart once again to the show. Richard has been here before, and Richard is really one industry expert that I've come to really respect and admire over the last 1 year or so. I think that we have engaged. He has deep expertise in medical device risk management through many years of industry and consulting experience. I wouldn't even try to count, and such a diverse range of experience in different settings. And he has seen practical challenges when we try to do risk management in practice. And as a result, I think he has come up with some very interesting ideas, particularly around benefit risk analysis. We hope to get a chance to talk about that. But today, we're going to focus on one big pain point in our practice of risk management in the industry, and that is the connection between risk management and design controls. And just to set the stage, guys, you know that FDA is going to transition into QMSR beginning February. And compared to the quality system regulation where risk appears only in one place, that's in design validation, too late after the fact, QMSR relies on ISO 13485. You all know that. And as a result, risk is everywhere. So we're going to talk about how risk connects with design controls, particularly what challenges people face and what might be some good ideas. But as I welcome you guys, you are part of this conversation. So don't think it's only one-way conversation here. Please continue to share your thoughts, comments, concerns, challenges, best practices, and we'll have a good discussion about that. So with that, Richard, welcome to the show. How are you today?
I'm good. Thank you, Naveen. I appreciate your inviting me here, and I'm really excited about this topic. I think it's a very key subject and is going to become much more so in the near future.
So, Richard, as I mentioned in my opening remarks, that QMSR is here, and unlike the QSR, risk is everywhere. So let's start with that. What do you think will be the big change that's going to happen? Beyond just procedures and templates and forms and how we do things, how should QA, RA, engineering leaders be thinking about regulatory compliance, especially from a risk management point of view? Can we start with that first?
Certainly. And obviously, we're going to be speculating here on what will be happening. But I think there's some pretty obvious speculation to make with what would be going on. If you ask yourself, why would the FDA choose to harmonize with ISO 13485 when they had the CFR, the Code of Federal Regulations, already in place? What's their motivation for harmonizing with an ISO standard? And I think the answer is pretty obvious. If you look at the two of those documents next to each other, 1345 is tremendously more specific about how to implement requirements that are in the Code of Federal Regulations. So I would expect to see a lot more detailed audit findings in the future for companies and medical device companies because of the QMSR as opposed to the QSR.
Yeah, that's a great point too, because I think QSR, at least to me, it reads more like a checklist of requirements. I cannot make connections, even though there are connections in our processes in the QMS. And that's what ISO 13485 clearly establishes, that QMS is a set of interrelated procedures or processes, and a process-based approach is required. So it'll be interesting to see how it unfolds. And we know that the QSIT is not out yet. We don't know what's going to happen. But I think we can read between the lines and we can speculate. Definitely, this is a platform where we share opinions. We can speculate whatever we want with an informed opinion, with the intent to have conversation. So Richard, let's come back to our original theme of the discussion today, which is the connection between risk management and design control. What kind of practical challenges you have seen in practice in this area?
I've seen tremendous challenges, is the short story. And just touching on the same topics of the QSR, I think it's a fairly well-known almost joke that the only place the QSR mentions risk is in the context of validation. So at the very end of the whole process, they say, and you should do some risk work too. And we all, of course, know that that's not the way to approach risk. We need to do risk from the start of the process. But that's not how our regulations are written right now. Certainly, the QMSR, the 13485, is written very much not that way. It's written to integrate risk throughout the entire process. And in fact, Section 733 says that you shall use risk management as an input to design, which is as far as you can travel from what the QSR has where it's only used in the validation work. And as you said very rightfully, risk is embedded throughout 1345. You can barely sneeze in that procedure, not have something that says, and do this on a risk basis. Everything is virtually written from that perspective, which is what the FDA asked us to do back in the 90s. We're simply starting to get some guidance in more particular fashions about how to implement that guidance in the past to make our decisions on a risk basis.
Yeah. And, if you ask around, if you observe how it is done in practice, we'll find that people will say, we have done FMEAs, design FMEA, process FMEA, software FMEA.
Yes.
We have done all that. So where is the mess? So let's talk about that, right? We have heard risk practitioners say that FMEA is not sufficient for risk analysis.
Right.
What kind of challenges does it really present? Because it's not that we are not doing risk analysis. Maybe we are not doing it completely and in a more structured, systematic way, end to end. Maybe that is the case. So let's talk about that.
Certainly. And I agree with you strongly that we all do risk analysis, risk management work. It's required, we do it. But the question is, are we getting the bang for the buck? Are we getting the benefit for the time that we put into the process that we should be getting? And I would strongly say the answer right now is no, that we can improve that significantly. FMEAs are one of the places that we can improve our return for our time. And I say that with great respect for what FMEAs can be used for. But FMEAs are applied to a design that's in its final stages of review. It's not a true design input. It's something that you do at the end of design when things are pretty much in place, when you can trace a failure effect from a failure mode to the effect it's going to have on the product and the patient. A very late in the stage process, and we really need risk management be done much earlier in the process. And they first have an idea of, here's how I want to do, here's how a treatment mode that I want to perform with a medical device. We need to start thinking right at that point before you even have an architecture, before you even have what countries it's going to go to. You need to be thinking about risk that early in the process. And that's not something that we are very good at doing in a systematic way. We certainly do risk management throughout the whole process. We are very good at considering risk management as we go through the design, but it tends to be very ad hoc work, and doesn't have a systematic framework that's put around it. And that's really where we miss the opportunity to leverage our time as well as we could. Everybody, I'm sure, has had projects where they worked on where you were asked to go back and we're just going to review the paperwork on this. We know everything is good. There's not really any problems here, but please get the paperwork in place. And inevitably, when you get the paperwork in place, you find significant problems. And that's really what we're missing with risk management. When we do it in an ad hoc fashion instead of as a formal process, we do what we can, but we're going to miss things, no matter how careful we are, though it could be caught if we did them in a formal manner.
So let's talk about that, Richard. Can you share just a couple of examples of what you have seen in practice where not doing it systematically has caused some issues, to the extent you can, without disclosing any proprietary information? Can you share some specific examples with us?
I think there's some well-known examples in the industry. My personal favorite one is a medical device for cleaning cholesterol out of arteries, and the device for doing that was basically for anyone who's familiar with arthroscopy, we used to clear out shards of chemicals from a joint, or that we used to shape the remaining cartilage in a joint. Someone put one of these cutters on the end of a catheter and wanted to use it to go clear out cholesterol that accumulates in veins and arteries, which sounds good at its first blush. The problem is they didn't think about the fact that these cutters are also very good at just perforating right through the walls of veins and arteries. That soon became a well-known failure mode after the product was introduced to the marketplace. And I think anyone who looked at risk even casually, systematically from the start, would have said, folks, this is a problem that we need to consider carefully. And it didn't happen because that preliminary conversation didn't happen. And the device was actually approved for use and was only used for a short period of time because that risk wasn't identified until it was on the market. And once it was identified, it was seen as an absolute death knell for the product. It was so obvious and so unavoidable.
Yeah. Now, of course, people might say, Richard, that hindsight is 2020. How can we prevent this from happening? And I think that's where I feel like we should emphasize the value of a process, creating a process.
Exactly.
It'll never be perfect, but it'll help you. So in this case, so let's play this out. We have read 14971 many, many times, and it is very nicely structured, very methodical in risk management and how you should apply it. In that context, let's share with our audience today what should happen. What should happen right from the beginning, and how we should go about doing this instead of waiting for failures to happen to let us know where the problems are.
So what we need to do is we need to start thinking about risk at the very earliest places in the design. I mentioned before, as soon as someone is thinking of, I'd like to treat someone doing this thing to them, this will certainly help someone's health. That's when you need to start thinking about, well, how could that thing go wrong? I have a method I've developed, and we'll be using it in a couple of weeks with a client, where we start right from the treatment plan and say, okay, now what are the benefits of this treatment plan? What are the risks of this treatment plan? And we keep going through and asking ourselves that question through the whole design process. We actually use the list of benefits and risks to design the architecture of the product that we're going to design. So I think all of us as engineers probably have been asked or instructed as students that you need to come up with maybe 10 ways of solving a problem before you pick one that you're going to go implement. And I would challenge the industry to the same thing, that you maybe pick, maybe not 10, but maybe 5 or so different ways of architecting a product, and look at how risk is allocated and benefits are allocated amongst those components of the architecture, and use that to pick a product architecture that actually minimizes the risk and maximizes the benefit to the patient. I think that would be a radical change to how we approach design, to put risk that early and to put it before the product is architected, and so many things are frozen at that point.
This is fascinating, Richard, and to the extent you can, I would love to learn a little bit more about that, because this is the first time I'm hearing somebody proposing an approach which combines both benefit and risk from the start. 14971 doesn't say that. What you are saying is that so this is fascinating to me, and I would love to hear more. So tell us a little bit more about how it works. I can imagine that maybe you'd settle on the intended use indication statement early on as much as possible. Yes. And then you start your journey. So walk us through that process a little bit in more detail. I think this is very fascinating.
So what you want to do is, again, we're trying to have a structured, formal way of doing this, as opposed to, well, this is the best I can come up with, doing it in an ad hoc fashion, which has lots of value, but doesn't have the advantage of doing things systematically, which is what we really want to be doing. So the approach we want to take is to make a list of what are the benefits of this product as you're doing it. Because as soon as you come up with a treatment plan, how am I going to help somebody? Write down what are the benefits of that treatment plan, and then start writing down what are the risks of that treatment plan also. How could someone be harmed by it? And you want to use that now, right at that point. You want to start saying, okay, now how can I go back and look at my treatment plan with the risks that I just had in mind? Could I modify my treatment plan to minimize the risk? And we're already doing risk management now. We're several steps away from even doing use case work, which can also be done very early in the stage before you have a product architecture established. And that'll be one of the things that will come after some initial work with benefit and risk and the treatment plan someone's envisioned. We can do some iterative loop right there with how can we use risk to improve the treatment plan, but then you move on to how we're going to use that treatment plan and make a set of formal steps that you would perform a use case plan, a use case scenario of the product. And you can use that now then to, again, go back and do an iteration loop of, okay, I'm going to use the product this step, this step, this step. Where are risks exposed? Where could I modify my steps to minimize those risks? And then again, when you go on to, okay, I've got these steps, what kinds of tools do I need to design to help me implement those steps in an optimal manner, benefiting the patient, minimizing the risk to the patient? How can I design those tools with those factors in mind? And it becomes your guiding principle as you're going through the whole design process. Once you have the tools designed, you say, okay, now how can I package those tools into a product? What's my product architecture going to be to hold these things in place that's meaningful, to help people use them properly? And so you're doing all this work with the benefit to the patient and the risk to the patient, both in mind, in the forefront of your mind, written down in front of you as you're doing these steps, long before you get to the detailed design work that most people would consider to start doing risk work with.
I understand, Richard, definitely. But I want to push a little bit further here, because I find this so fascinating. On the risk side, I think we have fair amount of clarity on how to do this. You start with intended use, you do reasonably foreseeable misuse, you do characteristics related to safety, you do hazards and hazardous situations, and so on and so forth. How do you propose we do it on the benefit side, where there might be a lot of conversation about just kind of marketing related benefits, and people might be confused with that? Do you have any
Thank you, Naveen.
recommendations on how to do that?
Yes, I appreciate that. I'm coming at this from a probably fairly unusual perspective, in that I've developed a method for doing benefit risk that makes benefit and risk both easily quantifiable parameters, and not only easily quantifiable, but I measure them with the same metrics, so I can compare them and I can do a benefit risk comparison then. And so these are concepts to me that are very concrete, but I know that's an unusual perspective. One of the perspectives that I found useful when talking about the benefit risk method, when you talk with clinicians about how they measure benefit, they look at a patient's health before treatment, they look at the patient's health after treatment, and they look for the difference. And that's what the method I've developed does. And so you simply want to look for, when you're doing your design work, you want to look for what benefits are there to the patient. How would this treatment improve their health, improve the existing health problems they have? How would those health problems be improved by this treatment plan? And those are the benefits. Those answers to that question are the things that we want to consider as benefits, and the things we want to optimize as we're moving through the design process.
I think I'm following you, Richard. Thank you for sharing that. And good news is that it's quantitative as well. How do we guide this process for most companies, where you may not have clinical expertise easily available in early parts of the design and development? They might have some vague idea about what clinical benefits it might offer, but they really don't know too much. Mostly it's driven by an understanding of what the market wants, where the gap is.
Yes, that's usually the focus. Exactly.
Right. So can you share some thoughts on how we can actually guide this process, help people go through this process without being overwhelmed? Because, let's be honest, they're already quite overwhelmed by tight timelines and launch plans and lack of resources, and they have to do all this documentation. How should they go about doing this in a simple and manageable way?
I would suggest simply having a list of the risks and a list of the benefits that you build from the start. It doesn't need to be an extensive document. I would suggest that you make notes of what design features you've modified because of those risks, what you've changed in your iterations of the treatment plan because of those benefits and risks. But this is still a pretty modest document. So I suggest starting that way as documentation. I would also offer that if you share what you're doing with your management, I would strongly expect that they would be nothing short of ecstatic that they were getting this kind of work done, and will be very glad to see the benefits of that in the product going forward. So you can, a few attaboys are always a good thing to be able to pull along with you as you're doing your work. They earn a lot of forgiveness for things that go on. But I also would offer that as you do design work with the benefit and risk in the fore of your mind, you're going to proceed more quickly because you're keeping the patient in mind from the very start, and that's what we all need to do. So this is only going to accelerate your design, not slow it down, because you're focusing on the endpoint, the patient, from the very start. And that's a very crystallizing or very focusing place to keep your attention in design.
Yeah, this is fascinating, Richard. Thank you so much for sharing this with us. We have already covered a lot of ground, but guys, if you have any questions, comments, or thoughts to share about this topic, this is a very fascinating new approach. If you have any questions and thoughts about that, please share them in the chat, and we still have some time to discuss that with Richard. So, Richard, let's continue on this. One benefit I see of this approach is this framework could be used throughout the development process. And,
Yes.
having done engineering myself, I know that design decisions always involve a trade-off. It's never black and white. There is a lot of gray zone, and as we have to make some decisions. And generally we say make risk-based decisions. But what I'm hearing you say is that risk is not isolated or absolute. It's in the context of benefits. That's how we should make those decisions. So tell us a little bit more about how this could be a little bit more beneficial in the overall development process, this new approach.
Gladly, and with extreme enthusiasm. Hippocrates that said, first do no harm, and encouraging people to think carefully about the medical devices and medical treatments they're doing to people. So first make sure you're not going to harm them before you treat them, which is a good thing, but that's only half the picture. And so if we only look at risk, we would never do anything, because if risk exposes someone to a chance of harm, the only reason anyone should be treated is because they can benefit from the treatment they're receiving. If someone's perfectly healthy, they shouldn't be treated for anything. But if someone has a health condition that needs to be treated, then that's when we want to bring a treatment plan in to help improve their health. So we never wanted to just look at risk. We always want to look at risk and benefit together when we're designing our products, because we have to have the opportunity for benefit or we have no business treating someone. So we need to think about the benefit that a patient can receive from our treatment and make sure that we always maintain the standard of the benefit exceeding the risk for the patient population and for the indication for use. Because it's a two-sided or double-edged sword that we want to do our design work with. And if we only look at risk, we're going to miss opportunities once again to enhance the benefit to the patient that we could bring forward if we were to consider both of those factors as we're doing so. It's not that people don't think about how to maximize benefit, but if you do it in an informal way, in an ad hoc way, you're going to miss opportunities that you would capture if you did it more systematically.
For sure. So, Richard, we are running short on time, but we do have a couple of questions. I want to address them very quickly. The first question is, if a medical device manufacturer already complies with 13485 requirements, is it safe to assume that it will meet new FDA guidelines? Is there any new FDA addition not covered in 13485? I can take that question, Richard. That is definitely not true. 13485 requirements, I would say, are majority of the QMSR, but QMSR also has very specific regulatory requirements that must be covered. Of course, there's a lot we can talk about it. So let's go to the next question. Is FMEA risk control document not a risk assessment document? Risk assessment is done with hazard analysis. That is a good comment. But there was a question here. Can we use FMEA at any stage of developing without having hazardous situation and sequence of events? I think you can talk about that very quickly, Richard. Address that question, please.
Certainly. So it's true by definition that if you don't have a hazardous situation, you don't have a possibility of harm. So you have to have however you analyze risk. If you're going to look at risk to a patient, as opposed to many other kinds of risks, maybe project risk or financial risk, but if you're looking at risk to a patient, you have to have a hazardous situation, or you can't have harm to the patient. That's just true by definition.
I think what I'm hearing in this question is, can it occur concurrently? You may not have a lot of information about or have not maybe detailed hazardous situation sequence of events, but we could also start our FMEA purely from an engineering point of view. So I think addition to your answer, Richard, would be you can do them, but they should somehow talk to each other and eventually land in a place where they are connected to each other.
Absolutely.
Interesting questions, guys. I know I don't want to keep you guys too long, but this is another good question about design freeze timeline with respect to process validation. Very specific question. Should we have design freeze before starting OQ, PQ of the manufacturing process? Because it might be the case during OQ, we might realize the production-wise process is not feasible. What is the ideal timeline to start process validation with design freeze? It's a great question, Richard. Go ahead. Please share your thoughts.
Yes, it is. So obviously it's a part of your validation is you can't validate something unless it's representative of your product that you're going to be selling. So you have to have something that is representative of your final saleable product configuration, product performance when you're doing your validation work. So by definition, it has to be a final design, but there's always an opportunity, and in the cases you talked about in the question, need to do a revision to identify something that was correct something that was identified in the validation work, and that's certainly possible and a good thing to correct.
Okay, let me add a little bit color to that, guys. Treat your process validation as part of the design process if you are starting from scratch. I mean, if you have a very established process, yeah, you could do it concurrently and maybe a little bit of work after design freeze, but really there should be a connection between your DFMEAs and process FMEAs. Because as Richard mentioned, that you may discover that some issues you may have to go back and fix from design because the process is not able to handle that, right? So design process is a very iterative process, and process validation is part of that. So I hope it helps. We cannot really go into too much detail with that, but you have to exercise judgment from a risk perspective. How much residual risk is still there because of your manufacturing process that is not covered by your design? If the balance is not favorable, you have to go back to the drawing board, maybe do something more. I hope this is helpful. But I can see that there's a lot of interest in these topics, Richard. Great conversation today. We are coming to our 30 minutes, and I hate to keep people longer than they need to be. So with that, Richard, please share just 2 or 3 key takeaway points for us.
Certainly. I think going back to the start of our talk here today, I think we should expect the audits in the future be much more specific with some of the details in 1345 that are not present in the QSR or the CFRs for the United States. And the nice thing is that since those things are lined out in 13485, easy to see, easy to identify places to augment quality systems, company quality systems that are maybe not as complete as they need to be to comply with 13485. And risk is a big area of increased focus. I think it's fair to say it's the biggest area of increased focus over the QSR to the QMSR. I think the biggest changes in the area of risk and the emphasis that's constantly put on doing risk-based decisions. Those decisions start at the very start of the design. They should start at the very start of the design. That's the shortcoming of you relying on FMEAs to identify risks. Is your design is pretty much solidified at that point. You're really tweaking the corners. Whereas if you go back to the very beginning of the process, we have a treatment plan that has no implementation envisioned yet, that you can use the opportunities that are present in a treatment plan to figure out how to design product that will minimize the risk and maximize the benefit. And I would challenge as a criteria for are you doing that is your architecture based on minimizing risk and maximizing benefit? If not, you aren't considering risk as early as you need to really do it properly.
Yeah, and your insight about thinking about both benefit and risks throughout the design and development phases is really amazing. So, Richard, with that, thanks again for taking the time to share your insights with us. I enjoyed this conversation. I hope everybody in the audience also did. Judging by the comments and questions, I feel like we had a good session today. But guys, I want you to know that this is your forum. So please reach out to me if you have any thoughts or suggestions for improvement. If you want to participate as a speaker, also please reach out to me. It takes no preparation and everybody is welcome. The only requirement is your passion for sharing your perspective. You don't have to have many years in the industry to come to the show. You don't have to have a big title. All you need is the willingness to participate and share your perspective with everybody else. Thank you again, everybody.